Hi everybody, my name is Katie Cook, and today we're going to be talking about gastrointestinal disease. So the topics we're going to cover today include gastroesophageal reflux disease, or GERD as I'll call it, peptic ulcer disease, or PUD, nausea and vomiting in general. We'll get into the specifics when we get to that section, and then gastroparesis. Just to let you know, this is a very high-level overview, as this is a lot of really dense topics, but I kind of wanted to just highlight the drugs that you might see most often and what you need to know about each of those. First, we're going to talk about GERD. Symptoms associated with GERD include heartburn, hypersalivation, and regurgitation. Diagnosis is if symptoms occur greater than 2 times per week. And the treatment algorithm is first to discuss lifestyle modification. So often GERD could be related to obesity or certain trigger foods, so it's good to have patients maybe keep a diary, try to figure out what the source of the reflux is. In some cases with weight loss, avoiding those spicy foods, avoiding caffeine, eating smaller meals can actually take care of the symptoms. So the initial drug treatment, if you're unable to use lifestyle modification only, is a PPI daily or proton pump inhibitor times 8 weeks. If the patients have nocturnal symptoms, then it can be increased to BID. Sometimes patients may not need to be on a PPI forever, so this treatment initially may help take care of the underlying issue. It could treat whatever the underlying problem might be, which we'll talk about when we get to peptic ulcer disease, and then come off of the PPI. But in patients that have chronic reflux, they may need to be on this long term, in which case they can use a maintenance drug treatment, which you hopefully will be able to find a PPI that works for them, or an H2RA, which we'll talk about as an alternative at the lowest effective dose. It's not recommended to use some of our other agents that we use in nausea and vomiting as long-term therapy for these patients. So first we'll talk about the drug treatment options for GERD. Antacids is probably the easiest place to start. These are widely available over the counter. Patients can get the calcium carbonate, which is Tums, or magnesium products like Mylanta or Milk of Mag over the counter. Dosing is variable, of course, depending on which product you use. Side effects can range from constipation to diarrhea, depending on the product, and electrolyte abnormalities are something to just keep in mind. If patients are taking these a lot, especially if they have renal disease, they can accumulate because they excrete their electrolytes, obviously, through their kidneys. You can also see some drug interactions with these products. They can bind to certain medications like fluoroquinolones, for example, so they should be separated from those. Our H2 antagonists you might see often, the famotidine, ranitidine, Pepcid, and Zantac. There are others, but I didn't list them here. Their dosing is also disease dependent, and there really aren't a lot of side effects. There's headache, sometimes confusion. It's also really important in patients that have renal or hepatic dysfunction to evaluate the dosing of these medications. They are renally excreted, so they have to be dose adjusted for patients that have renal disease. And then one thing I did want to mention especially was drug-drug interactions with a medication called cimetidine. I'm hopeful that this is no longer available anywhere, but I think it actually might be available over some over-the-counter pharmacies and places where you can purchase medications. And this medication has a ton of side effects, and it's something hopefully you haven't seen because people know better, and we're not recommending it as often. It has side effects with a lot of antiviral medications, antibiotic medications. It has interactions with blood pressure medications, seizure medications, warfarin, a lot of major medications that we have our patients on. So I would highly recommend avoiding this at all costs. We have other medications that work well, so avoid cimetidine if you can. The proton pump inhibitors, of course, this is kind of our bread and butter, so I wanted to focus on this area. We have omeprazole or Prilosec, which you can get over the counter or with a prescription. Same goes for Nexium and Prevacid. Protonix and Dexilant are prescription only, and then there is a combination product over the counter called Zegerid. I will say that the only thing to mention here with regards to prescription versus over the counter, obviously we interchange these when patients come into the hospital and go out of the hospital, and so some people have favorites, and that's fine. They can be interchanged. However, if you're sending somebody home on one and you want to say, hey, grab this over the counter, they're really kind of not very cheap. They're a little expensive, so I would recommend evaluating your patients individually and figuring out what kind of insurance they have, because even in some cases it probably may be cheaper to have their insurance pay for it than it may be for them to get it over the counter. So dosing, one of the things I wanted to mention here, the dosing is very simple, and you can use any resource, or they can read the back of the boxes on when they pick it up from the pharmacy. But timing of administration is really important, and it's drug dependent, and that also would be on their instructions on the back of the box. But I would recommend maybe letting patients know, hey, you need to be taking this sometimes on an empty stomach in most cases, but usually 30 to 60 minutes prior to a meal. So a lot of people will get up in the morning and that'll be the first thing they take before they eat. And then length of therapy is also important. I didn't go into details for every single medication, but it's indication dependent, it's dose dependent, and it's drug dependent. Usually it's anywhere from 4 to 16 weeks on these therapies. And again, this is kind of just a reminder that in reflux, it's not always that you'll be on these medications forever, but it just depends on the reason that you're using the PPI. So in some cases, maybe somebody that has H. pylori, they're going to be on it for a certain period of time. Or maybe if they have peptic ulcer disease, they're going to be on it for a certain period of time. So just monitor the length of therapy for these medications, because a lot of them have end dates. And so it's important to make sure that if the patient is able to come off of it, they can. Side effects include headache, nausea, and diarrhea. And a couple of cautions. I know everybody's kind of heard about these through the grapevine, that it can contribute to C. diff development, which probably is where most of the data is, and all of these kind of cautioned things that I have listed here. So just be careful and cognizant of that in your patients. If it's, again, somebody that doesn't really need it, just take it off. Osteoporosis-related fractures, hypomagnesemia. They've actually seen some incidents of increase of community-acquired pneumonia, and then again some drug-drug interactions, just a caution there. There are a couple key tips when you're starting a patient on it that might be helpful for the patient to know that's been having reflux and are annoyed by their symptoms. It takes several days for this to take effect, and even up to 2 weeks depending on the medication. So you have to tell people to be patient. It's not like a pill that you can take and all of a sudden their nausea or vomiting or reflux just goes away. And then to taper it off when you're discontinuing. A lot of patients have trouble coming off of PPIs because their reflux symptoms recur, and so it's important to let them know when it's time to come off of it that they may have to taper down off their dose, like taking it every other day or once a day instead of twice a day, that kind of thing. Okay, so next we're going to get into peptic ulcer disease. This may be present in the gastric or duodenal gastrointestinal lining, and it's most commonly associated with H. pylori, NSAID-induced ulcerations, or stress. So Helicobacter pylori, or H. pylori as we all know it, is a gram-negative bacillus that's transmitted via infected endoscopes, and it can be diagnosed by breath test, by serum, or by biopsy if you do an endoscopy. And we're going to get into the specific management and treatment of this on a future slide. I also just briefly wanted to mention NSAID-induced and stress-induced peptic ulcer disease. These are a little bit easier to manage, and I've listed that information for you here. Use a PPI for 8 weeks for NSAID, and for stress-induced, you can use a PPI as well. But we more often will be seeing these type of stress-induced situations in the hospital setting. So there are specific guidelines related to using stress ulcer prophylaxis, especially in the ICU and patients that are ventilated. And so that's where you may see that most often. Symptoms associated with peptic ulcer disease include dyspepsia and gastric pain. And just a couple of tips, with the change in pain for patients associated with eating, it might actually help diagnose the type of ulcer they're having. So patients that have pain and nausea and vomiting and they eat and it feels better are usually patients that have duodenal ulcers. People that have more pain or more nausea and vomiting after they eat will more often have gastric peptic ulcers. Okay, so first to talk about the H. pylori treatment. So usually, historically, we've seen a triple therapy with a PPI plus 2 antibiotics. However, in other countries and now in our own, we've seen an increase in use of something called a quadruple therapy due to treatment failure associated with the clarithromycin. So ideally, we would be able to evaluate our patients for risk factors for resistance to clarithromycin, which might be a prior exposure to a macrolide antibiotic in kind of the recent past, or high local clarithromycin resistance rates. In some cases, patients or areas will just assume that they have a high resistance rate and they'll just start using a quadruple therapy. So I would recommend that you talk to whichever institution you end up working for and kind of their standard of practice there. So the triple therapy is for 14 days, and that's a PPI BID plus amoxicillin and plus clarithromycin. You can replace either of those antibiotics with metronidazole if needed for allergies. And then quadruple therapy is for 10 to 14 days, and here you would use a PPI BID plus bismuth subsalicylate QID, metronidazole QID, and tetracycline QID. In either of these cases, you could substitute an H2RA for the PPI if needed, but the PPI is ideal. I also wanted to mention cytoprotective drugs, and this is actually something that you would see more often in that NSAID-induced peptic ulcer disease that I mentioned at the beginning. That's where you're going to be using that 8 weeks of a PPI. However, in some cases where the NSAID maybe can't be discontinued, you may see cytoprotective drugs, or maybe patients that are on long-term steroids that cause gastric irritation. These two medications are really solely for that purpose, is to protect the lining of the stomach. So Cytotec, the first one, has side effects including diarrhea and abdominal pain, but really what I want to highlight about this is that there's an enormous boxed warning, and that they use this for abortion, and it's really obviously a category X drug, and so it shouldn't really be used in any patients that are of childbearing age anyway, so just be extremely acutely aware of that. Sucralfate or Carafate has a side effect of constipation. It should be cautioned in renal impairment, and it should also be separated from other medications from 2 hours before and 4 hours after, because it can bind the medications as well. So nausea and vomiting, we're going to move in here. There's obviously a bazillion causes for nausea and vomiting. I can't even begin to list them all. Here's a few of them: infectious, food, pregnancy, chemotherapeutic agents, motion sickness, GI diseases, and lots of medications. For example, I was just going to mention some of the highlights. Metformin, we see a lot of GI disturbance with metformin, which usually goes away after a period of time. We see a lot of nausea and vomiting with our opioids, which tends to get better, but we will often pre-treat to try to take care of that, but it's extremely common. Every medication has a side effect of nausea and vomiting. Treatment of nausea and vomiting, of course, is to identify the underlying cause, and if you can address that, then try to do that. Otherwise, there are certain medications that are better for certain indications, which we'll go through. You can also consider non-pharmacological therapies in patients depending on the reason, if it's food especially. Small meals, low-fat diet, avoiding triggers, sometimes that can make things worse. It can also mean that somebody, for example, has like a peptic ulcer disease or a reflux, and they're having nausea and vomiting associated with that. So pregnancy-associated nausea and vomiting is something very common. I'm sure you get lots of questions about. Of course, we all want to use conservative management first in these patients, trying to identify triggers if we can. Some patients will even do hypnosis or those bands that they wear on their wrists. Anything that we can do to avoid medications in these patients is great. Some people will use ginger, and it's recommended to use ginger-containing foods or drinks. With regards to supplements like this, you have to be really careful because these aren't FDA approved, and so we can't necessarily validate their safety, and we also don't have as much data with regard to drug-drug interactions. So I caution its use regardless if they're pregnant or not, and if given, no more than 1 to 1.5 grams divided over 24 hours is recommended. There's also vitamin B6 plus doxylamine, which is an antihistamine, or it's also called Diclegis, and it is the only FDA-approved medication for this indication, and the dose is 2 tablets nightly. This is an all-inclusive list of most of the nausea and vomiting treatment options that we have available. We already talked about ginger, which can technically be used in any population. We have cannabinoid derivatives, antihistamines, phenothiazines, 5-HT3 receptor antagonists, corticosteroids, and benzodiazepines. Each of these kind of have a different niche or indication that they're best used for, and so we'll talk about each of those as we go through each of the medications together. Okay, so first we'll start with the antihistamines. You'll see them listed here, and the mechanism of action is that it has its antiemetic properties from an anticholinergic blockade at the histamine 1 receptor, and this decreases exocrine gland secretion. We see these most often used in motion sickness, so the Dramamine and the Antivert. Dramamine is a very common motion sickness medication that's available over the counter. People will use it for flying or for cruises. There are side effects associated with antihistamine, which we know, the anticholinergic side effects like sedation, dry mouth, blurred vision, urinary retention, and sometimes in pediatric patients we actually see a paradoxical excitation, and so they get really hyper, so just be aware of that. It should be cautioned in narrow angle glaucoma, benign prostatic hypertrophy, or anything that causes urinary retention, and then especially in the elderly. I'll just put a plug here. If we can avoid any antihistamines in the elderly, that is ideal. And because of these side effects like blurred vision and urinary retention, it puts them at a really high risk for falls. So I would probably recommend against using any of these agents in our elderly patients. So phenothiazines, we have compazine and Phenergan. They block dopamine receptors at the chemoreceptor trigger zone, as well as receptors acetylcholine A1 and H1. It's indicated as an antiemetic for a variety of causes. And what I'll say about this is I usually, in my experience, will see this used second or third line. However, it is most useful for treatment of nausea and vomiting versus prevention. So say, for example, you've already tried Zofran in a patient and, maybe some other antiemetic agent, and now they're actively vomiting and you need something to use, this would be an agent for that. And so side effects associated with this include drowsiness, EPS, agranulocytosis, and some anticholinergic effects. And it's contraindicated in Parkinson's disease, narrow angle glaucoma, bone marrow depression, severe cardiovascular or hepatic disease as well. And long-term use is not recommended. I'll also put a plug here if you ever use this in the hospital setting. Phenergan, for example, administration through an IV can be very dangerous if their IV is not working perfectly because they can have extravasation and it can also cause tissue necrosis because of that. So I would be very cautious if you ever have to use it in that situation. But again, this is really going to be something that you might see used more like in a second or third line when a patient is refractory to something else or are having active nausea and vomiting that maybe your first line didn't work for. Just for completeness, I wanted to include a slide on our only cannabinoid derivative, dronabinol. Its indication is generally as an alternative in chemotherapy-induced nausea and vomiting. I have seen it used in the operative setting, but it's more useful for treatment versus prevention. It should be cautioned in patients with a history of seizure disorders. It does have a lot of side effects, including psychiatric effects, tachycardia, hypotension, seizures, and of course an abuse potential. So for the reasons that you see highlighted here that are bolded, you don't see this used very often. But just for completeness sake, again, I wanted to include it. So the 5-HT3 receptor antagonists, there are many of these, but of course I have listed kind of our bread and butter ondansetron or Zofran, which we see all the time. It blocks serotonin peripherally in the GI system and centrally at the chemoreceptor trigger zone. Its indication is first line for patients with chemotherapy-induced nausea, vomiting, or post-op nausea and vomiting prevention. This is like the best agent to just give ahead of time if you know that something might cause nausea and vomiting, and it really works best if you really do give it ahead of time. It's hard to use this as a kind of a catch-up medication if somebody's already not feeling well. Second line, it can be used for patients that have cyclic vomiting, pregnancy off-label, and gastroenteritis. Side effects include constipation, headache, fatigue, dizziness, diarrhea, and one that we monitor probably most frequently is for QT prolongation when it's given with other medications that can cause QT prolongation. Corticosteroids, again, for completeness, I wanted to include this. The mechanism of action specifically for nausea and vomiting is unknown. You most often see dexamethasone used, however, methylprednisolone may be also used, and it's indicated for chemotherapy-induced nausea and vomiting. Side effects, of course, include glucose elevation, insomnia, anxiety, and it can cause gastric upset, unfortunately. Benzodiazepines, the mechanism of action binds to the receptors on the postsynaptic GABA neuron, and it enhances the inhibitory GABA effect, causing less excitable neuronal state and stabilization. It's indicated for anticipatory or breakthrough nausea and vomiting and may be more useful in patients that have refractory chemotherapy-induced nausea and vomiting. You can see amnesia with this, sedation and CNS depression, drug abuse, of course, and it's an enormous fall risk in the elderly, and for that reason should be cautioned. I put caution especially for these two things, elderly and abuse potential. I really don't see this used very often for nausea and vomiting, however, for completeness, it's So drug-induced nausea and vomiting, again, this is one of those things I was mentioning before, like with metformin or opioids. We see it a lot. It usually will respond well to antiemetics when you see this, and you've identified that it's a drug-induced nausea and vomiting case. And of course, discontinuing those inducing agents would be ideal if we can. Sometimes we know that things are going to get better, like with metformin, or you can titrate the dose a little bit slower. You can think about extended release versus immediate release. So there are ways around it. Of course, the most commonly used is the 5-HT3 antagonist, that's Zofran, and that's because it has extremely low side effect profile and most people tolerate it really well. Like nobody has an allergy to Zofran. Antihistamines might be useful long term if that's something that if it's a drug that they're on that they're going to be on for a really long time and we're trying to increase their tolerability. And again, dronabinol, that was the cannabinoid derivative, is only approved in chemo-induced nausea, and it can be used as an appetite stimulant. Motion sickness, antihistamines are good for this, acting on the vestibular system to control nausea and vomiting. It has a rapid onset with antihistamines and a long effect, and again, we use the dimenhydrinate or the meclizine most commonly in these patients. So Dramamine is what you'll see most often. It's important to remind people to take these medications before they start traveling because, again, it's not great for catching up once you already don't feel good. So it should be taken pre-travel. And then, of course, scope patches we use for this as well. There are many, many, many anticholinergic side effects. So a lot of times we'll have patients like try this at home before they go on their awesome cruise and find out that they have terrible side effects that they can't tolerate. It's also contraindicated with narrow angle glaucoma, chronic lung disease, and prostatic hypertrophy. Briefly, I want to go over gastroparesis. We're almost done. This is something that we see related to the muscles in the GI tract that don't function normally, and it just slows the process of your gut motility, interferes with digestion. There is no cure for this. It's only symptom management, and it's often associated with really significant vomiting. Risk factors are many. However, I will highlight the first one for diabetes. That is really where we see this most often, and it is recurrent in those patients, especially those that are not controlled well. So you may see this in patients that have diabetes that return often with these symptoms. There's non-pharmacologic management. You can use smoking cessation, actually, weight loss, which is supposed to help a lot, and then the same kind of non-pharm for the other disease states we talked about. So avoiding those irritants like alcohol, big meals, making them smaller, fatty or spicy foods, and then not eating right before you go to bed. Briefly, I'll highlight two of the most common prokinetic agents. The first is metoclopramide or Reglan, which you may have seen also used as a medication for nausea and vomiting. It does work for that as well. Its mechanism of action is dopamine antagonist, and it enhances acetylcholine activity in the GI tract. It accelerates gastric emptying and increases lower esophageal sphincter pressure, and that's why we specifically use it in gastroparesis. It does have side effects like EPS symptoms, drowsiness, depression, and it can elevate aldosterone, and it's contraindicated in patients with Parkinson's disease or mechanical obstruction. For the reasons of the side effects that I've listed, you may not see this used often in the nausea and vomiting population because I didn't mention it there, but it does work for that. And because that it has this mechanism of action to accelerate gastric emptying, it's usually a first-line prokinetic agent in gastroparesis. The other agent you may see is erythromycin, which is actually a macrolide antibiotic. Its mechanism for its use here is really unknown. It does have side effects like drug-drug interactions, and it can prolong the QT. And it's contraindicated in patients who have an allergy to macrolide antibiotics or in certain combinations due to drug-drug interactions. This concludes the presentation. If you all have any questions, please feel free to reach out. Otherwise, we will see you in class in a few weeks.